Hello out there in lecture land, it's Deb Miller. I'm just going to record another short lecture on quality health care, and some things you need to know is that, it's important that we deliver quality health care, and going to share a few terms with you that you're going to hear as you begin your career in nursing and start to work and such, and some of the importance of why we focus so much on delivering quality care. Think about it from your standpoint. You'd want only the finest for you and your family, so it stands to reason we need to know what tools to use and how we go about evaluating that health care, and why it's important as nurses we give quality care. So here's a little quote: you've got to know where you are before you can get where you're going. So I hope you all agree with that. Got to know where you're at so we know which way to proceed, okay? Got to know which way to proceed. And think in terms, while we're doing this lecture, what does quality health care mean to you? What does it mean to have quality health care? Okay? So who comes to play in this? Who are the key players? Well, the nurse's role, right? In order for quality health care to be realized, and it's the nurse's role because we deliver the care, so it's about accountability. We strive to deliver the finest care, evidence-based care, efficient, accurate, but we're held accountable for the care we do deliver. It's got to be quality, and it's got to be cost-effective. We can't just haphazardly waste supplies or waste our resources. Wouldn't it be great if we could all have just 2 patients apiece? But that's very costly. So, we talked about that yesterday. It's costly, so therefore we might have to have more than what we'd like to have patient load-wise, but we have to be cost-effective. Other key parts of quality health care and the deliverance of is improve patient outcomes. If we're providing quality health care, then it stands to reason that we're going to have great patient outcomes. What do you think lousy care is? Lousy care. That's right. Maybe inconsistent care, maybe substandard care. You're absolutely right. But think in terms of how you would define lousy care. Nothing's ever on time. The medicines are wrong. We have to send those back. I have to wait a long time for my pain medicine. When I call for help, no one ever comes. Maybe my nurse is less than professional, or maybe she's rude. And so when I think of lousy care, I think of that. So you're all very aware of the scope of practice, the Board of Nursing's guidelines. There's a standard of care. And that describes the kind of care patients can expect and should receive from nurses. Okay? Now, you've all heard of Joint Commission, and we're going to talk a little bit about Joint Commission. There's a standard. There's standards of care that have to be delivered for each and every patient. Now, depending on the patient's diagnosis, we go one step further. There's core measures. So we have rules and guidelines that help us to provide the care that we're supposed to. It's the standard. It's okay to go above and beyond, but it's not okay to give substandard care, okay? You wouldn't want it, neither would you want your family members to have it, so we're not going to deliver substandard care. So, how do we go about delivering care, and how do we know that it's correct? There are quality improvement tools in place in every facility, and some use different tools to evaluate evaluate the kind of care patients receive, such as they'll send out those surveys after you're sent home, after you're discharged, and they'll ask you to rate the care you got. HCAHPS, we heard about HCAHPS in a presentation. They want to know what kind of care you got, were your needs met in a timely manner. Well, we're going to go one step further. We want to look at quality improvement methods, and that includes tools and forms and techniques that we use to deliver the quality care. And oftentimes these this methodology, if you will, is used to enact changes. So the first one we're going to talk about is the DMAIC. It's used to enact a change, or to analyze something that has changed, or to determine if we need to make a change. Okay, it's pronounced DMAIC, but most folks call it the DMAIC. All right, the D stands for define. This is to help us to define the issue, possible causes, and goals. So we're trying to evaluate for quality health care, a continuous improvement, if you will. Okay, the M is for measure. We're going to measure the existing system with metrics. Okay, we've got to get a baseline, right? Okay, very good. And then the A is for analyze, and that analyzes the gap between existing and goal. So, we got to analyze what we have now, where we're at right now, where we want to go. All right? And then we have improve. We're going to improve the system with creative strategies. It's kind of like the nursing process. Would you agree? You got to identify the problem and then come up with a plan. And then C, control, is control and sustain the improvement. So here's the thing. If we're looking to improve something, we don't just improve, put a plan in place and then forget about it. It's an ongoing, it's continuous improvement. And in order for that to happen, we've got to build in some evaluation and some sustainability, if you will, okay? Now, I'm not going to ask you on the test to diagram a problem and work it through, but I just want you to be familiar with some of the words that you will hear on the unit when they're talking about enacting a change or improving something, or, they've identified a cause for maybe increased urinary tract infection. So they're going to do their own study, if you will. So there's different tools that you can use, and the Six Sigma, you'll hear that quite often. But that's just a quality improvement method. All right. Well, you have your PSDAs, PDSAs. It's plan, do, study, and act. And that's kind of like a care plan, if you will, the nursing process. You got to, plan, make a plan to improve something. Okay, and it's to help enact a change. So you lay your plan out, you carry it out, and then you study it to see if that was effective, and then you act on it. And by that, that's part of sustaining it, all right? You can also do a root cause analysis. There's other improvement methods, or, tools, if you will. This is just a small list. There's even brainstorming. Here's my thought. Start with something easy and attainable, and then work your way up. When you brainstorm, you're sitting around talking about it. However, we might not get beyond that talking about. So if you put in the DMAIC system, that probably will help you come closer to enacting a change, okay? So, again, I'm not going to ask you to memorize these. I just want you to be familiar with this, or just have heard these terms, okay? Another piece of the toolkit when we're talking about enacting changes or improving healthcare, as a result, we come up with critical pathways, care maps, and care plans. We got to have a plan. We got to have the directions, if you will, to care for a patient with a particular disease process, and so we know how to do it, but we have to keep track of how we did that. So, hence, that's why we have the pathways, the care maps, and the care plans. Okay. In healthcare, we have a special obligation to strive for perfection, because instead of making products, we serve people. Anything less than pushing for perfection is unjustifiable. I hope you all agree with that. We do have a special obligation to strive for perfection. That's why we tell you we can't take shortcuts. And if you leave out a step, then, will we really get quality health care if we're leaving out steps and taking shortcuts? No, our patients deserve to have the very best. They deserve perfection. Okay, so the purpose is to achieve optimal patient outcomes in terms of both improved well-being to the extent possible given the patient's condition, of course, and then patient satisfaction with care within a well-functioning system while keeping costs to a minimum. That's quality health care. You're getting the bang for your buck. Now, I also believe that you get what you pay for. So, we're not we talked about rising healthcare costs and, that sort of thing. We want to keep the cost at a reasonable minimum, and sometimes you have to spend a little to get a little, but, you keep your cost at a minimum while providing optimal care, okay? And some other terms that you are going to be familiar with and you'll hear is quality assurance, quality improvement, and performance improvement. It's the process or activities that are used to monitor, evaluate, and control services providing some measure of quality to consumers. So again, how do we know we're doing what we're doing? We gotta track that and be able to monitor. We gather the data, and then we evaluate that. Historically, the focus of quality improvement was in controlling processes by inspection so that errors were prevented. Emphasis has changed from proactive approaches to error prevention. We want to look at preventing errors, okay? That's part of quality health care, preventing errors. Okay? Let's look at some agency accreditation and some verbiage that you'll need to be familiar with, okay? Healthcare accreditation and licensure. Well, the purpose of that is accreditation is a formal process by which a recognized body, usually a non-government organization, assesses and recognizes that a healthcare organization meets applicable, predetermined, and published standards, okay? Published standards. Licensure is a process by which a governmental authority grants permission to an individual practitioner or healthcare organization to operate or to engage in an occupation or profession. Now, Board of Nursing, they're going to issue your license when you pass your exam, and they're saying that you are given permission to practice in your profession. Okay, Joint Commission will come around and evaluate hospital organizations, facilities, and such. Okay, the NLN AC accredits us. Our nursing programs are accredited, so it's a formal process. So we sit through accreditation every 8 years, and so to make sure that we are meeting the standards and we're providing the education that is appropriate. So here's some examples. Joint Commission, you've all heard about that. You've all heard about Joint Commission, and at some point in your nursing career, you're going to be in the hospital when Joint Commission comes around to make their visits, okay? And then another accrediting agency is your Centers for Medicare and Medicaid, and they typically look at hospitals, but they look at some ambulatory facilities as well, some of your smaller clinics and such. Okay, Joint Commission, who are they? It's an independent, not-for-profit organization. They evaluate and accredit more than 16,000 healthcare organizations and programs in the United States. They have maintained the state-of-the-art standards that focus on improving quality and safety of care provided by healthcare organizations. There's a standard that has to be met. And they come through and they evaluate and they look for those standards to make certain that those facilities are meeting the standards. Now, if you don't meet the standards on some of it, depending on what you don't meet standards on, they'll give you suggestions and you'll hear people call, we got dinged for that, we got dinged for this. It's just to give you an opportunity to improve. And then they may come back and make a revisit. So who's the CMS? That's the Centers of Medicare and Medicaid Services. They're formerly known as the Healthcare Financing Administration. It's a federal agency responsible for administering Medicaid, Medicare, HIPAA. They're responsible for that, SCIP, and CLIA. Okay? These are just terms I want you to be familiar with. Let's look at hospital performance measures, core measures, and you probably have heard about these. Your book does a really good job of talking about core measures, but we focus on that for our reimbursement rates, okay? 3.6% for hospitals that successfully report quality measures in fiscal year, and if you report quality measures and great patient outcomes, that helps drive some of your reimbursement from these agencies, okay? Now, this agency is not paying for certain conditions acquired in the hospital, such as foreign object retained after surgery or pressure ulcers, because that's not quality health care, right? They're not going to reimburse for mistakes. So if we don't do our job of documenting that we have turned the patient, and the patient develops bed sores, the hospital's not going to get reimbursed by these agencies because we didn't do our part, okay? So it's real important that we follow the core measures, we follow the standards so that hospitals can get reimbursed. And if hospital gets reimbursed, then chances of you getting a raise are greater, okay? So a little bit more on the core measure sets. Now, predominantly, it's procedural measures that we look at. Did the hospital engage in proper procedures for treating a patient with a diagnosis? Okay? You got a denominator, the patients who should have received a certain aspect of care given diagnosis and other conditions, and the numerator is patients who did receive the aspect of care. So they look at protocols, they determine if what percentage of patients received the care they're supposed to get, and what percentage didn't. Okay, but it's real important that we had a guest speaker the other day about documentation. It's very important that you document everything that is appropriate. If you didn't document it, it didn't happen. And if for some reason this patient had a diagnosis and was supposed to receive a certain aspect of care and didn't, not going to get reimbursed, and you're providing substandard care. Okay? Some reporting requirements, and again, this is just stuff for you to think about. Not necessarily going to make or break you on the test, but you're going to hear this kind of verbiage in the hospital. Hospitals submit data on about 30 quality measures to receive full payment. So they collect the data that, everybody that had a UTI, we followed these set of guidelines, if you will, and we've evaluated the patients that had that diagnosis, and we followed the rules. So they're going to submit that data for payment. However, they submit on 30 measures, but some agencies require up to 72 measures. So hang on just a second. Okay, sorry about that. Joint Commission, beginning in January of 2008, their discharges, in order to meet the standard, hospitals must not be a negative outlier for 3 or more consecutive quarters. So in other words, we can't have a lot of negative or poor patient outcomes, if you will. Here's a list of some sets and different measures, and I'm not going to have you commit those to memory, but I just wanted to put those up there. But you just need to know that patients who come in the hospital having an MI, there are 11 measures at least, and this number is subject to change, but there's guidelines that you have to follow in order for patients to have considered quality, standard care, and for reimbursements. Okay? And here's one broken down for your acute MI. Aspirin on arrival, at discharge, and so on and so forth. And certainly, whenever you have these particular diagnoses, there's a lot of comorbidities that go along with it, like patients with MIs, do they smoke? What's their cholesterol levels? You have to look at the whole big picture, but that kind of follows that through. And again, I'm not going to ask you to memorize any of that, but I just wanted you to be familiar with some of the pieces of some of the core measures, okay? Heart failure. Certainly everybody gets discharge instructions, but pneumonia measures, that's something that you'll see on the charts, okay? And again, I'm not going to ask you to memorize these, but I just want you to be familiar with them, okay? And I think you can read these slides. They're pretty self-explanatory, okay? And a few more. National Patient Safety Goals. Let's talk a little bit about that. These goals and requirements are guided by the Sentinel Event Advisory Group. Each year, they work with the Joint Commission to undertake a systematic review of the literature and available databases to identify potential new goals and requirements. So, your core measures and such, they'll add more in, okay? They'll add more measures, and certainly we have groups looking at Sentinel events, and you all know what a Sentinel event is, don't you? Let me just give this to you. It's a Sentinel event is an unexpected occurrence involving death or loss of limb or function, called Sentinel, because these occurrences are in need of immediate investigation and response. Anytime we have a Sentinel event, the hospital is required to report those errors, okay? And there's usually extensive follow-up, okay? Let's say a Sentinel event when perhaps somebody, the wrong leg was removed. Now they have the timeout and surgery, and they mark them and everything, but, the wrong limb was removed, patient receiving the wrong blood, and he dies. That's a Sentinel event, okay? That's a Sentinel event. Okay? One of the goals is identifying patients correctly. Patient identification. We use at least 2 patient identifiers when providing care, and oftentimes more, but we don't just walk in and call somebody by their name. Now we have to check their bracelet. We check a lot of things, and same with our medications and such. A lot of places have gone to the barcodes, and so we're going to scan several different places to make certain that we have the right patient. And you all know that. You've been in nursing school, getting ready to graduate, so to check the armband for the medical record number or for the patient's name. You don't call them by the name, you ask them their name. We do that each and every time. Each and every time. Okay? Another goal is to improve staff communication. It's the effectiveness of communication among the caregivers. When you're taking a telephone order, we all know about read back, SBAR. We've changed a lot of things, how you take an order down, how you write an order. We have those no-nos that you can't use on the chart. You don't use U for unit and QD for every day. You have to write these things out. Why? Because it prevents errors, and that's the focus. You gotta prevent errors. All right. We have a standardized list of abbreviations. If it's not on that list, then it can't be used, okay? It can't be used. Let's see. Let's do some more. Medication safety. That's a great big one when we're talking about patient safety goals, patient safety, quality health care. This all goes together. Improve the safety of using medications. The requirement is we create a list of medicines with the names that look alike or sound alike, and we update those. There were times when patients were getting the wrong medications because of something that sounded very similar or even looked alike. And, we didn't always have the Pyxis system. They were putting just regular slide in, slide out drawers, and we'd roll our carts up and down the hallway to give medications. We've come a long way, and even though it's in a Pyxis system, you still have to check the medication labels carefully, because humans fill those systems up. They fill the Pyxis up. But, you never give a medication that's not labeled, where the container's been cracked, or even the label on the container is smudged. You can't do that. We label all of our medications, the containers, the solutions. We put them in Ziploc bags with the patient's name, and we keep them separate. We don't put stuff in our pockets. That's part of patient safety. And the requirement is so that we reduce the likelihood of patient harm associated with the use of get the wrong med. But another big medication safety focus is on anticoagulation therapy. You have to label it. You have to label all meds. You label anything that you're going to take into the patient's room and give as a medication, even down to your saline. Okay, but, many years ago there were some problems with anticoagulation therapy, giving you heparins and all. Folks were getting overdoses of heparin because of the different strengths. There's one heparin for flushing ports, or it used to be, and then there's other for sub-Q. You have to be very careful with that. And then, of course, you got to, there's a lot that goes into giving patient heparin. You got to check their lab work as well. Okay. Another patient safety goal is healthcare-associated infections. Well, what's the best way to manage that? That's right. That's absolutely right. Wash your hands. That's going to reduce the risk of healthcare-associated infections. You got to wash your hands. You have to comply with the CDC hand hygiene guidelines. Our facilities around here make us check students off on hand washing. Requirement: manage essential events, all identified cases of unanticipated death or a major permanent loss of a function associated with a health care associated infection. There's no excuse for not washing your hands and following the rules. And how many times have you seen folks go into rooms, in isolation rooms, they're supposed to have gowns and masks, and they don't. It's real important that we follow those guidelines, the suggested guidelines, okay? You just have to. Not even for a second are you supposed to walk in. If you're going to touch that patient, and sometimes you go in the room thinking you're not going to, and perhaps you do, so you got to be real careful. Just if it says to gown and glove and mask, then that's what you need to do so you don't carry that to other patients, okay? Another requirement under this goal is accurately and completely reconcile medication across the continuum of care. Find out what medications each patient's taken. Make sure they're okay for the patient to take any new meds with current meds. Okay? Give a list of meds to the next caregiver or to the regular doctor before the patient goes home. That all falls into this goal to reduce the risk of health-associated infections. Make sure we know what antibiotics they're on. Make sure we know what meds they're on that might affect their antibiotic that they're taking, okay? And if they're going home, make sure that they are aware of how to take their meds. And if they're not being seen by their regular doctor, we've got to make sure that those meds, or somehow a record gets to their physician, okay? Another huge goal is to reduce falls. That's a problem in any facility. We want to reduce the risk of patient harm resulting from falls. Most places have a fall prevention or reduction program. Everybody has to be assessed for falls, and you have to document it, okay? And then you're going to find out, which patients are more likely to fall. It's not just your elderly patients that are most likely to fall. Patients on medication, certainly patients out of their comfort zone. Maybe they've had surgery, or maybe they have an illness and they're dizzy. So we have to be very, very aware of that. And you all know that. Help patients to be involved in their care. Tell each patient and their family how to report their complaints about safety, okay? Teach patients and their family how to report complaints about anything, like their care, or if they have questions. Encourage and take the time to let them ask those questions, okay? Identify patient safety risks. That's another patient safety goal. We need to identify patients at risk for suicide, okay? And y'all had that lecture about suicide. You ask them if they have a plan, but, we have to identify patients at risk for suicide. Patient involvement. We encourage the patient's active involvement in their own care as a patient safety strategy. Patients who are involved in their care are going to be more compliant too. Would you agree? So, we need to define and communicate the means for patients and their families to report concerns about safety and encourage them to do so. So, by doing that, we're getting them more involved. Okay? Okay, pressure ulcers. Certainly we want to prevent healthcare-associated pressure ulcers, your decubitus ulcers. We're going to assess and reassess some more each resident's risk for developing a pressure ulcer and taking action to address any other risks. So if you got a patient that's bedbound, they're at risk for pressure sores. Anybody that's going to be in bed for more than, several hours, they're going to be at risk. Okay, you got to look at why they're in the hospital. And you got to assess and reassess and reassess. Okay. Risk assessments. The organization identifies safety risks inherent in its patient population. So in other words, if it's PEDS unit, so within the patient population, whatever unit, say the PEDS unit, they'll have some safety risks. Falling out of a crib, maybe these, little kids, sometimes they, they're a little top heavy, and maybe they are still toddling around, or, kids are at risk for getting injured, and, so we have to, as adults, we have to help them stay safe, okay? Maybe on a behavioral unit, a risk assessment would be your risk for suicide, okay? Changes in patient's condition. Let's see. Improve recognition and response to changes in patient condition. The requirement is select a suitable method that enables staff to directly request additional assistance from a specially trained individual when the patient's condition appears to be worsening. For instance, and this would be an example would be cat call, the cat team. You're calling a code overhead. So most facilities have their own specialized team that respond to all the codes, and so that hospitals have instituted that to meet this goal, so that they're minimizing the risk there. We've kind of already talked about this. The universal protocol for preventing wrong site, wrong person, wrong procedure surgery. The requirement is to use a pre-op verification process, such as a checklist, to confirm appropriate documents are available. We implement a process to mark the surgical site and involve the patient in the process. Prior to start of the procedures, a final timeout verification to confirm it's the right patient, procedure, and the site. Each person has to actively participate by saying, I agree. I mean, it's not just the doctor and the scrub nurse. It's everybody. Okay? So, surveying and scoring the national patient safety goals. All applicable goals and requirements or acceptable alternative approaches must be implemented. So all the things that we just talked about, they're going to implement. It's been implemented, and they got to go back and evaluate. The surveyors evaluate actual performance, not just the intent. So it's important, if it's not documented, it didn't happen. So they're looking for actual performance, not, I meant to. Okay, and the requirements are either compliant or not compliant, and failure to comply will result in a requirement for improvement. Okay, and that may lead to no accreditation or no reimbursement. Okay, and then there's public disclosure of compliance with the national patient safety goals. Some patients, they shop around for their hospitals, they shop around for their facilities, they shop around for their doctors to see who's giving quality health care and what are the surveys saying, okay? And they look at the reports, and it helps them to determine from a consumer standpoint, is this quality facility, is this quality care, okay? For more information, you can always go to the Joint Commission website. Now, we'll tell you this, when you're out precepting in at different hospitals, it's interesting, if you go into their break room, you look at their bulletin boards, chock full of information, with things from Joint Commission, National Patient Safety Goals, CUSIN, HCAHPS. It's real important that you read the bulletin boards on the units that you're on. And once you start working, that's a communication board. It'll help keep you abreast of what's going on, keep you focused, and so you feel engaged in your unit, and when they're starting to talk about core measures and here's Joint Commission, you're very well aware of what they're talking about. Okay, so one more slide, I think. Oh no, I'm gonna share one quote with you. It's by Sir Winston Churchill. A pessimist sees the difficulty in every opportunity. An optimist sees the opportunity in every difficulty. So, there's lots of opportunities waiting on you all. Thank you very much.